looking at the pulmonary valve, to look at the valve en face requires a special look. It's almost always seen in a sort of a long axis of the aorta, because the valves are crossing each other. So if the one is facing in a long axis, the other one will be seen in short axis. So here's a matching a specimen, and I'll just turn it down so that it looks like the echocardiogram. Much easier to turn the specimen around than the echocardiogram. So we've got aorta here, and then you've got the pulmonary valvular leaflets here, and this is mild pulmonary stenosis, as you can see, with fusion of the commissures. This is not the same patient. I'll match the specimen. It almost looks like a tricommissural valve with a partial fusion of the commissures. So echocardiographically, we look at many things about the valve. Certainly in children, the subcostal or subxiphoid approach is the best approach. You can see here sort of doming of the valve leaflets with thickening of the leaflet tips, and this valve doesn't separate like a normal valve, but remains as an aortic dome. It's an excellent way to interrogate the heart by continuous wave Doppler, because the flow velocity is absolutely better aligned in this projection than many others. And you can use Doppler color flow to indicate the flow disturbance that begins just below the orifice of the valve and is associated with a minor degree of tricuspid pulmonary regurgitation. And after balloon valvuloplasty, this is what you see sometimes, obviously a different patient. Now the cusps are quite redundant. They still look a little abnormal, but they have a minor degree of tricuspid regurgitation. And I mean, you can almost appear this as a three-dimensional image, because at the commissural apposition areas on both sides, you see the three cusps together, there's a little leak. Additionally, and I'll show this in later detail, you can see here some fusion of the cusp to the sinotubular ridge area and a mild narrowing of the supravalvular part of the pulmonary artery here, and a little bit of pulmonary regurgitation. Another feature that we see with all stenotic valves is a post-stenotic dilatation of the main pulmonary artery, I think seen very nicely here. Really, if you see the valve annulus here, which is small, there's some subvalvular hypertrophy. You can see the jet striking this dilated area of the valve there, and really quite a substantial degree of enlargement of the main pulmonary artery. Also associated in this case with pulmonary insufficiency, almost providing the features of a TET-absent pulmonary valve syndrome. Sometimes the valves are bicuspid. This is a patient actually that has a tetralogy of Fallot. The annulus is small, and you can clearly see the bicuspid nature of the pulmonary valve. We assess pulmonary regurgitation as we do for aortic regurgitation. We look at the slope. It's less reliable than the aortic, because the pulmonary artery and end-diastolic pressures are usually much closer aligned. In the condition which is almost akin to the pulmonary atresia, this is critical pulmonary stenosis. The difference is there's prograde flow across the pulmonary valve that you can see in this right-hand panel here. There's marked hypertrophy of this ventricle, and these patients are also, in some sense, ductus dependent. You see the origin of the pulmonary artery with the doming in the region of the main pulmonary artery on this right-hand panel here. Four-chamber view. You see something that looks like a VSD. It's not really a VSD. It's just there's so much hypertrophy of this right ventricle that the blood gets trapped in the trabeculations and undergoes acceleration. And of course, this is definitely not pulmonary atresia, because you can see the right ventricular outflow tract with the flow into the pulmonary artery. There's marked right ventricular hypertrophy. The parietal band of the crista is hypertrophied. You can see there's increased coronary blood flow because you can see the coronary really well. The valve domes in the subcostal position, and there is both stenosis and insufficiency running in a very bizarre direction along the superior, anterosuperior aspect of the valve, and then bouncing back off the valve. And these are the branch pulmonary arteries. And again, you notice the hypertrophy, the domed valve, and the increased size of the pulmonary artery here. Tricuspid regurgitation, I showed you a picture of this before, with the very small hypertrophied ventricle, but, and with even suprasystemic pressures in the presence of supravalvular stenosis. Here's an example of doming. I've slowed the speed of this down and increased the frame speed for capture so we can get a slow motion view of the valve. And you see it doming perfectly in systole with the orifice of the valve clearly identified here, about 2 to 3 millimeters. If you come across into the long axis here, you see the pulmonary artery in short axis, and this is clearly in the same patient a tricommensural valve with a really quite minimal opening. And, of course, the secondary right ventricular hypertrophy, which is part of this condition. Physiologically, the atrial septum gives us some information about the diastolic properties of the two ventricles, and I think you can see that the diastolic stiffness of this right ventricle is compromised, and as a consequence, with atrial contraction, the atrial septum billows into the left atrium. This is a patient with near pulmonary atresia. You see a plate-like opening. If it wasn't for the presence of Doppler, it would be difficult to define that. Now, I want to mention, in addition to just looking at the valve and the artery, it's very important to look at what's happening at the sinotubular level, because it can make a problem for balloon valvuloplasty, because this valve is not only crowding in the sinotubular junction, may be impossible to balloon a valve like this. Here's another example of supravalvular narrowing. You can see the main pulmonary artery narrowing at the junction of the sinotubular ridge here. Doppler color flow gives you another idea of the size of the orifice within the valve. Now, this dysplastic pulmonary valve that I'm showing you here is quite common in Noonan syndrome. You can see, and these patients also possibly don't have as successful balloon valvuloplasties as patients without the Noonan syndrome. They frequently have the sinotubular crowding, and the valves are dysplastic and difficult to balloon. Doesn't mean that they won't try and do it, but it does mean that the chances of an excellent result are somewhat less than in other patients. Now, moving to the branch pulmonary arteries, we can see the branch pulmonary arteries well from a number of different planes. This is a high parasternal cross suprasternal view. It's the so-called three-vessel view that the obstetricians like to use in fetuses, showing the first vessel being the superior vena cava, the second vessel being the aorta, and the third vessel in a row being the pulmonary artery. We look at branch pulmonary arteries from subcostally as well, and from other positions, but here you can see a very nice example of a pulmonary artery which it appears to be mildly narrowed. There's I think I've mentioned this before, I'll move on, but an example of tremendous hypertrophy of the ventricle as a consequence of the load, the pressure load on this ventricle. And also please note the hypertrophy of the septomarginal trabeculation, or the moderator band echo, which is separated from the rest of the ventricle. Pulmonary regurgitation can occur with valvular stenosis. It can occur without valvular stenosis, and here's an example of a really reasonable degree of pulmonary regurgitation. And I would say that I would prefer to assess the regurgitation on the pulmonary valvular jet from a number of points of view, rather than look for the deceleration time on the pulmonary diastolic signal. Now, we used to talk a lot about this condition of idiopathic dilatation of the main pulmonary artery. The thing is, I think that color Doppler has sort of murked the waters of the clinical syndrome, because with this, there are always minor pulmonary valve abnormalities seen. As you see here, minor degree of pulmonary insufficiency, not much in the way of stenosis, but a pulmonary artery diameter going out into the branches is at way above what you see in the normal degree of pulmonary stenosis. Okay, and with the pulmonary artery, I think the best way for evaluating pressure by Doppler is this peak velocity. Again, I think mean velocities provide a more accurate estimation of the true pressure at cardiac catheterization than the peak velocities. Tricuspid regurgitation provides a number of interesting pieces of information. Again, if we look here at this image, just looking at the color flow with the tremendous hypertrophy, you can see the atrial septum bulging into the left atrium and the tricuspid regurgitation temporarily indefined by the color flow method. But when you look at the Doppler, you can see that systole occupies almost the entire cardiac cycle and that diastole occurs for a very short period, suggesting that this is a very non-compliant right ventricle. Now let's look at the branch pulmonary arteries. We look at them with both regular imaging and color flow, and we can look from a variety of planes. Here again is the three-vessel view, and we see in this patient that there clearly is a tubular hyperplasia of the right pulmonary artery from its junction with the large main pulmonary artery all the way to the hilum of the right lung. And I've shown that in these other images as well, just to show you examples of different patients that present a uniform type of pulmonary arterial pathology. Now, this sometimes occurs in the Williams-Van Buren syndrome. I didn't mention that in the aortic signal, but here's a patient with supravalvar aortic stenosis. You can see the crowding over here with the aorta, but what I wanted to point out to you is that in young patients with Williams syndrome, there's frequently branch pulmonary stenosis as well. And here you can see the left branch. It's the left branch because we're looking at the left ventricle behind here. So a sagittal subcostal plane showing the origin and continuation of the left branch of the pulmonary artery. Another condition where you see this besides Williams syndrome is Alagille syndrome, which has hepatic biliary problems as well as branch pulmonary arteries, peculiar facies, named after Professor Alain Alagille from Paris. And you can see here a quite profound degree of peripheral stenosis of the right pulmonary artery from a high three-vessel or high parasternal view to a regular view showing the left pulmonary artery and the right pulmonary artery being equally small. And then the velocity gradients here determining the peak velocity, and there the velocity in the main pulmonary artery clearly showing the acceleration occurring above the position of the valve without valvar stenosis. Here's an angiogram of a patient with Alagille syndrome, just to make comparative imaging characteristics, and you can see really the profound nature of the pulmonary hyperplasia of the branch pulmonary arteries. Here showing the left pulmonary artery, I think we saw the right from a different projection. And I think, once again, one has to emphasize that in looking at all of these vessels, sometimes you'll see one in one view, sometimes you see them in another view. Now, this patient on the top left is a patient with Marfan syndrome, a disease usually which presents on the left side, but when Marfan syndrome is profoundly affected, there is frequently regurgitation of the right atrioventricular valves, what one would expect from a metabolic disease. And I think you can see really quite remarkable degrees of pulmonary insufficiency here. Now, I'd like to finish off with a little test for you. So you have to all put down your pens and follow the screen. This is a 3-kilogram female patient that we were called to look at with good APGARs, but looked like she was a little blue. And the clinical examination was really insignificant. There was the usual non-specific systolic murmur, but the saturations were not quite normal. And the cardiac X-ray showed a normal silhouette with mild hyperinflation of the right lung and a slight shift of the heart to the left. The ECG was normal, and despite weaning on oxygen, she remained with low saturations. So what do you do for a patient like that? Do you do an MRI? No. Do you do a 3D echo? No. You do a standard 2D echo. So here you go. I've done that. You weren't paying attention, Dr. Sanders.
Did you have a murmur? I didn't hear it.
Very soft, non-specific systolic murmur at the left upper sternal area. So here's the first picture, and this is a parasternal short axis view. Here's the aorta, and here's the main pulmonary artery. Here's the left pulmonary artery. And there's a subcostal view, and you can see accelerated flow in the left pulmonary artery. Okay? And it actually looks a little small, doesn't it? I don't want to put words into your mind. So then we get a Doppler signal in the left pulmonary artery here. And that's the signal. It's gone down to 3 meters per second, which is, I think, abnormal. And there's continuous diastolic flow into the pulmonary artery. And when you withdraw the signal from the right pulmonary artery into the main pulmonary artery, there's clearly a velocity difference. And we can infer from that a pressure drop. Okay, and here's the echocardiogram from the 4-chamber view with color. So the ventricles look like they're pretty much okay for a neonate, and there's nice pulmonary blood flow, pulmonary venous blood flow, I should say. Nothing much happening at the atrial septum. What was abnormal about that, I'm not going to tease you about it, was there was nothing happening on the right side. There was only certainly a little origin of the pulmonary artery on the right side, and not a complete picture as you expect to see. And the pulmonary venous return was all coming from the left lung. So we said, well, the only structure we haven't seen is an absent right pulmonary artery. And so we took the child to the cardiac catheterization laboratory and confirmed the diagnosis. And then we did a pulmonary venous wedge, and we found that the patient actually had a nice pulmonary circulation. So what do you think is the pathology here? Anybody? Besides Dr. Sanders and Dr. Shirali. I didn't hear. Somebody mentioned something. What did you say? You can only be wrong. I mean, nobody's going to say anything if you're wrong. Or right.
Or right. They could be right.
He could be right or wrong. Here we go. You have two possibilities. And you won't be remembered for either. Well, we thought this was, what happened was there was a ductus on the right side, and the ductus had constricted off.
Isolation of the right.
Isolation, and so we gave the patient prostaglandin at 3 days of age. And look here, what you see off the base, confirming Dr. Sanders' earlier findings, the base of the innominate artery is starting to come off a little thingy, which as we progress further gets even bigger. So I'll let this play. And then looking at the lateral picture, there you can see from the aorta that the main pulmonary artery is filling, and both branches are seen now because there's actually a little ductus here. Okay? And so this was two ducts, and one constricted off that wasn't connected to the pulmonary artery or to the arteries. And all that happened was the patient went to surgery and had the artery anastomosed and is doing well. So congenital absence of the pulmonary artery.
Well, isolation. Isolation. It wasn't absent at all.
But you know what? If you see somebody like this at 10 years or 12 years of age and you don't find it, what? They still have pulmonary arteries. Very small, and you can't do anything about it. The point about recognizing this in the neonate is you can then do something and save this person to have a normal 2 pulmonary arterial system.
No, it's important to make a diagnosis early.
Is there something you want to share with us? Are you trying to say something to me? Oh, okay, maybe not. Who's next?
I don't know, Gary's